Oh, stop it.
Do I have an extra USB port?
That I do not know.
I think I do. I'm gonna put it quicker.
We might have to stop share if you, and then reshare. If you're planning on. Okay, we'll see.
I just want my button. Let's see if it works.
Uh-oh.
Maybe not. It's okay. You don't need it. Oh, well, that's not working either.
Yeah, it is. We tested it. Oh, there you go. Oh, it
Oh,
turned
it timed out. That did something.
MFG IYK. Do you need to log back in? There we go. All right.
Okay. All right, my thingy doesn't work, but that's okay. This will still work. Okay. So this is kind of I guess a niche subject. Okay, my name is Chris Comfort. I'm the certified health physicist. I manage the clinical radiation safety program at UCSD. And I forget, Bridget, you had this was your idea to kind of, I forget exactly, I think I reframed it here in the title, but basically, like, as hospital systems grow, how does one kind of not only like check on the safety culture, implement the existing safety culture, but sort of make sure that when you're going to a different organization, whether it's through an acquisition or some other, like a full acquisition or some other type of thing, how do you like integrate from a safety point of view? And some people might realize, so UCSD recently acquired like a full acquisition of formerly Alvarado Hospital, which is now East Campus, and it's UCSD. So I'm going to use that as a frame, but there's a few people in this room that are very familiar with UCSD, but a lot of people that aren't. So I want to devote a little time to this to actually just explain just what our program our medical program entails, because regardless of who you're acquiring, what you're capable of doing, you can can manifest at your acquisition, regardless if they're currently during the services or not. So it's important for context to see, well, what exactly do we do at UCSD? And it's a lot. We do a lot. I'm not going to ask you to read this, but sort of it's there symbolically is we do a ton of stuff. Our medical program is massive. Trainings, ALARA, dosimetry, emergency response. This is kind of both programs together between laser safety, RF safety, but I mean, it's huge. We do therapies, diagnostics. It's the scope of services at UCSD is huge. We're also, I think, Corey, you can correct me if I'm wrong, we're still the only level 1 burn trauma in San Diego.
Yes.
So we do joint exercises with the Navy, because if there is a RAD event on a military base where there is a fire and potential RAD exposure, they come to us. And so we do joint exercises with them every year. So yes, big program. And we do have an in-house diagnostic medical physics, which kind of helps with shielding designs and stuff like that. But we still, it's very big. Even for them, it's a large program what we're dealing with.
Chris, how many staff in the radiation safety? Wow.
So quick so we have, which is common for in the UC system. We have one RAM license that covers both research and health,
Mm-hmm.
and so the radiation safety program lives on campus, and so total I think we've got 12 people. Rad safety's 12, and then we have our system. We have one RSO. who's campus-based, not super operationally involved in the health system. We have 2 ARSOs, and an ARSO managed medical, ARSO managed campus. Then I have 2 high-level HPs that I manage. And we do have some campus support for but really the bulk of the entire rad safety program for the health system falls on 3, we have 3 CHPs, 1 PhD and 1 master's. And so I'm the least educated on my team. But so I rely on my team big time. And so, so we're a small team. And just like everywhere else, not just, I'm gonna, say it, it's just like, no matter where you go, no matter what you do, it seems like these days, you're being asked to do more with less and be grateful for it, right? So if those are challenges that we all, no matter what industry, what we're doing, we're having to deal with, and it's no different right now as a hospital.
Is that because of cost, or because there aren't enough HPs to do more, or?
Cost mostly, yeah. I can't get a position. It's just budget wise. The leadership's just being pressed. There's just no money, even though we've done a really good job of justifying that we should have more staff, but it's just the way the budgets are. It's just really difficult.
Are there people you can hire if you had budget?
No, that's it. Because medical health physics is so specialized, it's a real challenge. So again, I don't want to slight tangent. It's not gonna, it's worth mentioning. When in 2022, I hired for what's a specialist 3 health physicist, which is in the medical side. I interviewed 3 people. One of them was from Sloan Kettering, thinking it was a research position. Another was from, I don't even know where they're from, but also thought that it was like a PhD scientist position. And then one who had a vested interest in coming to San Diego, who came from academia, who had a year experience operationally, and that's who we went with. And so, and I would have had to open the position again if that person wouldn't have worked out. So you're right, it's extremely difficult to get this specialized, not early career medical health physicist, but mid-career. But so here are our 3 main sites: Jacobs Medical Center here in La Jolla, Hillcrest, and now East Campus. So those are our 3 sort of hubs of what we have. But it's not only that. UCSD also has everywhere from, now it's Vista. We've got a clinic that just opened up in Vista, which is off the map, and then we go all the way down to here. We have almost, I think, 23 separate facilities doing radiation besides the main hospital complex. Most of those facilities are just like a single radiography machine. Doesn't matter. They still need dosimetry. They still need training. They still need to make sure that they still need the oversight of a radiation safety team and professional. So the scope of UCSD is just spreading. We recently had, it's not a joint power authority, but it was another agreement with El Centro, because El Centro, which was servicing, they're out here somewhere.
Way out farther.
Way out further. They're servicing, they're in trouble. We came in and helped them. Luckily, we're not having to take over the rad safety there, but I'm still having to make sure our radiologists know that, we're actually owning their radiology, the reading and everything. But luckily from a rad safety perspective, we're not being asked to do anything yet. And then we just had a joint power authority with Palomar Health. And again, right now from the rad safety perspective, that we're not changing programs, but we're still being advised to make sure they fill out the paperwork correctly. And they're a consult. They have no radiation safety staff at Palomar Health. It is a consult. So, and we have an option to buy in 7 years. If they decide we buy, then that can be interesting. Either then they better have it in a budget to keep West Physics on, or they need to give me 10 to 12 more people. It's their choice, but, that's kind of the scope of the program right now. So it's big. And so regulations, everybody here knows, it's NRC, it's FDA, it's DOT, it's the state. And then by proxy, San Diego County for our X-ray stuff. And so we're beholden to a lot of things when it comes to acquisitions. Not only that, not necessarily from the rad side, but from the licensing side, just general CDPH for acute care licensing. That's a whole nother thing. But they don't really talk to RHB, but we're mostly RHB, and then obviously the county by proxy. So with that too, just the scope of our program, the size of our dose monitoring program at UCSD is massive. So I mean, these are total badges through the year, but really a better metric to think of is we have over 2,000 individual badges, right? I mean, it's not, there are programs nationally that are bigger, but there are also a lot that are small. That's a big program, 2,000 individual badges. It's big, yeah, it's big. And again, covering 23 sites. And so it's a big program. And unlike others, so right now we do all our in-house, we don't rely on the dosimetry company for all we do is get the reports. We do all our ALAR investigations in-house, and we process all the data in-house. And so that takes basically our campus AR, so at least a half of FTE goes to his dealing with dosimetry, but it's the operational physicists, me, Kayla, and Naz, that actually do the investigations for all ALARs. So it's a big program. And now we're flirting with getting Instadose. Don't know if you told that, Corey, but Nuke Med, we're getting Instadose for Nuke Med. Yeah, so we're hoping, we're hoping, just to kind of, well, Landauer sucks too.
I worked at Marriott.
I know, but again, I know, but I'm tired of doing an ALAR investigation 2 months after the fact, you know, I don't like it, you know. If Landauer comes, I mean, I've piloted their view badges, they're awesome, but yeah, I know, and I've been working with Marion's customer service, there's no, you know, it's a lose-lose no matter who you go with. It's Radico, I hear, is okay. But again, it's
So logistically, how are you? What platform are you using? You got a great return rate, 85%, 88%. But you know, logistically, that's
with the incident. So we're piloting it with Nuke Med, which is only that's going to be 30 badges and some spares, but that's multiple sites. But and even if we decide to expand that, I'm not. So we badge conservatively. Because what we found years ago that so if you're a nurse working in a fluoro suite, you're getting badged, because we'd rather show you 5 years of data saying you're getting less than 10 milligram a year than having to do a theoretical dose calculation that's going to be inaccurate and not help. But so we'd rather have the data do the talking than us having to perform calculations to satisfy somebody that's worried that they're getting dosed. So we administratively it's a burden, but it's worth it because we want the data of the badge data to show that people aren't getting anything. The Instadose administratively is going to be easy because it's one badge, they wear it and they can commute with it, and integration of dose reports, it doesn't have to be as hard as it sounds, but yeah, no, it's like, and our return rates can vary, but I mean it's been years of really trying to train people to get their badges in on time. So big program, right? And again, so nuclear medicine, PET CT, multiple, and that's growing too. There's another site in Rancho Bernardo that's a ground up, that's gonna happen, that's gonna have PET. So we have PET in 3 locations right now. We're doing RAI, Y90 microspheres in 2 locations, Hillcrest and Thornton. And right now, Pluvicto and Lutathera radiotherapy right now at Hillcrest. And then radiation oncology, we're doing high dose rate and external beam radiotherapy, and also gamma tile. Anybody doing gamma tile? That's cool for glioblastoma. That's been a fun one, because that's a multi-department thing. So Radon kind of owns it. It's done in the OR at JMC, so we have non-AU surgeons that we're having to train. We're in there during the craniotomies. We're doing the rad safety. That's a big one. And then not only that, the literature is clinical staff is okay, nurses get this much. No, there's no national literature about what PTs or OTs are getting. So we've created the program to actually where I'm getting all of our PT and OTs dose, tracking that, and there's a good paper in there. So I mean, but that was in the literature, nobody was talking about PT, OTs, only nursing staff. So that was something awesome UCSD's done. But another thing, UCSD, we have a reputation. We take on the most complex cases, and in the literature, they're like, oh yeah, no, because the release rate for cesium-131, 6 MR per hour at a meter, they're like, no way, you're never gonna get above 2, you're never gonna get above 3. These are the reps, these are the people that sell you gamma tile. Our first one was 5.9, and it's just and so we're just we're creating shields so we can still release them. We're doing and what we're doing with gamma tile here is pretty cutting edge, which is cool. But we didn't put that. But that type of, that's for glioblastoma. That doesn't even mention the alpha stuff coming down the pike right now. There's a few, we're doing the Converge study. There's a few studies, but the alphas are coming down the pike. But they have issues with, cyclotron issues because of that contaminant. Actinium-227 is a major problem. Right now, for our study, we're guaranteed none, but any in the future, any theranostic that uses actinium-225, if there's any chance of actinium-227, you have big problems for your program. Again, so yeah, radiology, just neuroradiology, breast images, mammography, multiple mammography sites, vascular, so I think at number of x-ray tubes right now, it's pushing 280, 290 across all sites, and so, and that's not even including campus, that's just in the hospital. So all that's to say, huge program. What happened, so you're gonna acquire, so this is really the slide that, everything was built up to this slide. Let's actually talk about the issues of when somebody acquires a license. So your due diligence, right? So basically, you're told that we're about to buy a hospital, and it's a full takeover, meaning you will own this program, you will now take over the radiation safety program. In this case, they had no staff. So if it turned out they did have staff, you would have to figure out a way to integrate that staff. It'd actually be better if they did, because then you can get some skinny. But here's the thing, we had an NDA, right? So we couldn't even talk to anybody. We couldn't go in, from rad safety, we couldn't even talk. We couldn't contact the RSO. We couldn't do anything. I can call the state and say, hi, Kathleen, what's what, did you guys give these guys any violations? And I can do that. But also too, their RSO was contracted out. It's very rare. I feel like having actual in-house rad safety is not as common. It's common in UC, but other systems, it's not as common.
Could you explain a little bit more about the NDA? Like, who was that for both parties?
Well, yeah. So above my pay grade, whatever they decided, like I think it was to protect current staff at Alvarado, because it wasn't at that point. Maybe certain people weren't going to be rehired as UCSD employees. Okay. And so to protect the staff, where all of a sudden, so imagine, so it's not just rad safety, you have 36 service lines in the hospital, everywhere from IT to pharmacy to whatever, including rad, we're a tiny percentage of that, going, oh my God, what are we inheriting? Everybody wants to bomb rush this hospital. And so the NDA is like, no, you can't just go in there and cause havoc,
So was that in effect until the acquisition was
Yes.
completed? Okay, so you couldn't find out any
Flying blind.
ahead of time.
Flying blind.
That's crazy.
Yeah, and I don't, again, so I mean, I've only been a part of one acquisition, and I don't know how common that is. And I mean, it kind of comes down, because like, but it makes things harder because you can't really do anything. And I mean, I'll say it now because we're down the, but I found out who the RSO was, and I called him regardless of the NDA, because it was the only, I wouldn't have done that had they been in-house. If they were a Alvarado employee, I wouldn't have done that. But because they were contracted, I was like, I'm gonna give this person a call. And we talked, and I was like, okay, how'd it go? And there, and it's okay, like prior violations, and this will come more kind of into here. But that's you're checking, like, okay, how good's their program? And the best way to assess that is what's their prior violations. So that's materials and machines. And compared to compared to how big our program was, East Campus is tiny little nuke med. They don't do therapies. I mean, how many injections do they do, or how many? One a day, one patient a day. I think they had 17 tubes or something like that. No mammo, and so it was, in your back of your head, you're like, this is gonna be cake, but it's never cake, because it's still a hospital, a physical hospital, right? So that's kind of that's what you want to do, your due diligence, but an NDA can hinder that. So you kind of have to get tricky. And it's leaning on, so I have a great relationship with our licensing people, really high up. If the closer you are to the executives, the better. And to try to get info where you can to work, can you circumvent this stuff? But next comes RML amendment, right? And so this was actually a tricky one. we thought, so at the time, so this was winter of 2023, I think, and it was just thought that we're just gonna put them on our license. No big deal, right? We're just gonna, but that, at that time, the state was going through some changes, and a lot of hospitals are just gobbling up other hospitals, putting them under the RAML, and the state's losing revenue. So the state finally said, no, you're not just gonna, they're gonna have to have their own RAML. And so we had to actually, and we were in a weird time because we applied for that amendment to put like their program on, basically just take that as a facility under our RAML. We were literally like one of the first ones caught up in that sort of maelstrom of the state going, no, we're gonna stop that. And so that was a big problem for us because we didn't know where we were at, what was gonna happen. Eventually we did not get the amendment. We had to keep their RAM license. So our RSO is now on the license, but guess what? They're not a type A broad scope. We're a type A broad scope. That's a problem the state hasn't quite figured out yet. Like, well, okay, well, how do you, like, so I have to call them every time I want to add a location? We're not used to that. You know, every AU I get, we have to put on the license. We're not used to that. We vet them through our RSC, and it's a done deal, right? So there's problems. If you are a hospital and you acquire another hospital, if you have two different types of if your license is not type A broad scope or whatever that allows you those certain freedoms in 10 CFR 35 to where you don't have to notify the state about every little thing you do, it goes through committee, then that's problematic, right? So that's something to keep in mind for these types of things. Policies and procedures is a big one because another one, okay, like how much do you just like come in with a wrecking ball and be like, you're gonna do things our way or the highway? You know, you're dealing with staff, so they kept, but it's not like they just fired everybody and brought in new staff. These are people who have been working there forever. And that's where you kind of look to, okay, well, what do their violations look like? And it's like, well, not many. Ron, you know, use log stuff, you know, or the weekly log, right? Which is common administrative, you know, for fluoro, where you gotta like, you know, document, you miss a couple weeks and again, you know, it's not a health and safety code violation, right? It's an administrative one, usually a minor violation, still a violation, but, you know, so yeah, they had a few of those, no health and safety code violations, no major issues. And I'm like, how much do I want to mess with them, you know? And it turns out not much. Like let it go. Like because how they were sort of determining during an X-ray inspection, how they were determining certain things, we would have a different procedure, but their procedure worked just fine to their inspector. I'm not going to go in and change that and risk them making an error in that. I'd rather come in. And it's funny, we're due. Van's due to come to East Campus. I've got my inspector here, the boss, so I'm trying to be careful here, you know, what to say. But I know Van is coming soon, and we're going to be ready. But the point is, like, we haven't had an inspection since our acquisition. If Van comes in and starts going, no, then, okay, well, now we know. But I'm not going to, like, a priori assume the worst and make them do a bunch of changes that may or may not actually be necessary. I'm going to go by the record. The record's good. And let's see how it goes. And that leads us to here, cultivating relationship. Immediately, they don't have rad safety staff. And so their radiology director did everything. It was immediately hanging out with her, spending a lot of time with her. And that worked because, you know, it's great, you know, because I think that's probably the most important thing. Any takeaway from this talk is figure out who's in charge at the other institution and befriend them and be friendly and get to know them and let them know you're here to help because they're going through it too. And if you're lucky and you guys get along and they're a good person, it's going to make things so much easier. And I feel really lucky that at East Campus they have a fantastic director. And so, but what if it wasn't? What if they were terrible? Then that could have been a different kind of thing. But luckily, I think it's turned out to be so good. Again, that doesn't mean that there's still not challenges, because you know there's still kind of like, hey, is there gas in the car? And she'll say, yeah, the windshield wipers are good. You know, and so it's like, wait, no, let's make sure let's make sure that okay, let's take a step back. I need this, you know. So that's still happening, but I think cultivating relationships is the biggest part. I mean, the staff integration really comes from that because it's all top down. You got to figure out who is who from a RAD perspective, who is there, who is in charge, and it's all top because they know her as the leader, not me, right? And so if we come in, because then if you come in with a good relationship with her, then she will vouch for you because the staff will be like, well, who's this person? And then their leader will be like, no, it's okay. And that just speed things along, right? So, that to me, cultivating relationships is the biggest part of any acquisition. Obviously, if the prior violation list is like crazy, and if it's a real, so we almost acquired Tri-City, and we pulled out of that deal, and why are you laughing? Do you know about Tri-City?
My best friend is a nurse and Tri-City, yeah.
Yeah. Apparently, it's a disaster. But
She was like, before the UCSD acquisition, she was like.
before Alvarado.
Yeah, when she heard about, we moved across the country together and she heard rumors, basically everyone told her, do not go to Alvarado and do not go to Tri-City because you will be worked to death immediately and
Yeah.
That's my context.
Yeah, well, and there was an NDA for that too. I mean, so I couldn't do any due diligence. Luckily, that deal didn't go, but because if that deal went, this would have been a different presentation. But again, so with the Joint Power Authority for Palomar, I think last I checked, I think they had 4 RAM licenses. They had 5 X-ray facilities. We have an option to buy in 7 years. So in 7 years, I could be inheriting a whole big, a Poway campus, an Escondido campus, Mamo, Radonk, the whole thing, like and so, but 7 years is some breathing room. We've got time to figure that out. But any questions? That's all I've got. I mean, again, first year lessons. After Van comes and sees us, that'll be the test, how we did. Because at that, we try. Our job is to keep obviously safety first, but then next is keeping the regulatory car on the road, right? And so, again, we do everything we can to make sure everything is doing well. But like we said, it's like what it's inspectors. I know James very well. I've gotten to know Anna very well. Van's still new to us, but the few times, Van's just great, and so that's too your rapport with your inspectors. It's like all that does come into play, and so when he shows up at East Campus, and it'll be a learning thing. Cause say, okay, how successful were we, and actually, do we have to change? But that's going to be the big test, and that should be coming before the year's out.
So we have one of your team at present for the inspection?
We liaison for all inspections. Yeah, every single inspection. So our RAM inspection cycle is a little different because of the scope of our program. We do medical RAM is every 6 years, just because it's like 2 years campus, 2 years, then they do like facility, and then 2 years medical. So our medical RAM is the gap is wide, and that is state. X-rays on a 3-year cycle. So, but fact, we have 23-ish facilities. Multiple times a year, we're getting visits from Ron's team to come in, and we're always there, because we're always learning something new. It's just great. I mean, I've gotten close to James. I mean, I came on the medical side since 2018, and we're friendly, He tells me, so it's like, and that those things matter because it's like, it's just those things are important, being close with your regulators is a huge thing. But yeah, no, part of our we liaison with every inspection, and that's becoming more like even accreditation stuff we're being more involved in, which is like with TJC and AAAHC, which is annoying, but we realize the importance of those organizations to the medical side because of Medicare payments and stuff, even though when they dip their toes into RAD, they're doing so probably not, they mean well, but they don't know what they're doing usually. And so we have to kind of like, we have to deal with that. You see that. Do you see the TJC, like how you guys deal with TJC and RAD?
Oh, yeah.
Yeah,
And we show up for every TJC survey,
Yeah.
and every MQSA inspection, and
Yeah.
every CDPH X-ray inspection.
yeah, you have to.
Yes,
Mhm.
we have one of our team physically present and supporting the inspection.
Yeah, it's good. It's good. Yeah, 'cause, you know, coach. A lot of people aren't used to it, and they're like, "Oh, I have this binder here. Here, let's open it up. Let's go. You know, oh, and there's a binder here. Let's do that." That's all I got. Any more questions?
Question,
Yeah,
You
Renee.
mentioned about HP stuff, but what about your tech, how many?
So we, over the years, so we don't have techs dedicated to the health system. We used to have for certs. We would have our techs drive to the facility to perform the surveys, but it was just way more efficient to train the nuke med techs to do the surveys. It's just because our techs could be 40 minutes out, because we didn't have, so the techs were based on campus because they had campus duties, and then they would get the call, have to drive to Hillcrest to do, you know, the cert surveys. It's just, and as the program grew, it just became untenable, and so we now have the nuke med techs doing a lot of that tech sort of work. We still rely on the techs for quarterly surveys. They will help us, like, you know, if we need to, for dosimetry stuff to help, like, you know, collect badges and everything. But and we have our own meter calibration program, so they'll calibrate meters. We're not calibrating ion chambers anymore, but they'll calibrate, you know, the count rate meters and stuff. And so, but yeah, no, we don't have any dedicated techs to the health system.
Are your nuclear medicine technologists unionized?
No. Well, yeah, they are. They are union. Yes.
Okay.
Yeah, they are union.
So, you know, it's kind of nice to look around the room and see the next generation of RSOs, health physicists. But I'm wondering, like, how, you know, it's difficult to recruit for these positions. Where are you tapping into your talent?
I haven't had to hire somebody, and since 2020. Again, like I said, I interviewed 3 people, and 2 of them thought it was a research position. And so so there you go. I had one, and if she didn't work out, I would have had to reapply. So no, if I had to get another spec 3, I have no idea how to do that. If I can get a spec 2, because I could train an early career.
Right.
I could train an early career. But if I had to get someone, like, if my principal medical physicist left, who's in charge of the nuke med program, if she were to leave, game over. No one can do what she does. So.
How about AI? Can't AI do all this?
No, unfortunately, no. I put ChatGPT in the weeds. I was trying to model an X-ray tube in MCMP, and so I was trying to feed ChatGPT a bunch of DICOM data, and I got it to infinite loop. It couldn't figure out DICOM data. It was like, well, number 45 is this. Oh wait, no, it's this. It's this. It's this. Oh no, I got it. I had to shut it down. Couldn't do it.
Love that.
So, yeah, with rad stuff, with AI, you gotta be careful because it hallucinates often. It's bad. I don't know how. Yeah, do you guys use it all? You have to really check because it's dicey.
It's funny because my boss keeps encouraging, like, all the CSUs are like very pro AI. We're doing this. We're gonna do this. And so my boss keeps encouraging me, like, oh, you should use it. You should use it for rad stuff. I'm like, I trust calculators with math.
It's fine. I mean, honestly, it's fine, but you're not gonna have less work because you have to check everything. You have to check everything.
If I wanted to
So
proofread something, I'd get an ARSO.
Yeah, right. Yeah, sure. Yeah, so, yeah, but I'll first admit I use it, but again, it's with a grain of salt because it's still error prone.
Really well, but
Yeah.
you know, the checking is.
Yeah.
You
Or
know,
where the sources come from.
Yeah.
Yeah, they don't. It doesn't cite, right? It just,
They don't?
It just, yeah, no. So I don't know. Did I go not long enough? Sorry, guys.
No,
Something-
no, it's perfect.
All right.
Yeah.
Any other questions?
We have more questions.
Sure. Oh yeah, hit me.
So, what kind of oversight do you have for, the new facility? Like, do you do quarterly audits?
So nuke med gets audited quarterly. We do X-ray areas annually, and so how we so it depends on so how we divide, so like you have a hospital, you could have cardiology, you can have IR, you can have, certain, urology. Like our bigger hospitals, we have like separate areas, like urology, they've got their own CR. It's like we almost call it like, it's like an internal satellite facility or something. So we kind of like audit those separately. And so for East Campus, so yeah, because it's smaller, but so yeah, Nuke Med gets quarterly. And then the X-ray areas annually, and there's we break it up into CT, cardiology. It's smaller, general X-ray. The East Campus is small enough to where we can do that, but the bigger hospital like La Jolla and Hillcrest, we have multiple like sub satellites within the hospital as far as X-ray. And then Nuke Med's a constant thing because it's like a Nuke Med's like alive. It's crazy, it's different than the X-ray stuff, right? So.
What can you tell us about the safety culture compared to,
So
the hospital?
so it depends. So physician culture is its own thing, and so with physicians, I find, are there any physicians in here? There's some that are just, there's some that, they're old school, they don't care, they don't wear their badge, they don't care about their badge, they treat you like you're a pest, and that's fine. At least I know what I'm getting. But there are physicians that claim to care, but then they won't wear their badge, they don't do anything, but they claim they care. And and that's almost worse. I'd rather them just say, screw you. Like, I got into this. I've already had 2 cataracts burned off. I don't care. Get out of here. You know what I mean? And fine. Like, I'm okay with that. But it's like there's physicians, and the culture of leaving dosimetry badges on lead is just endemic. Like, there's like nothing you can do to just get them to take their badge off and put it on the board. It's just not gonna happen. And so we get our false ALARA count. It's like I'd say 85% of all our ALARA investigations are false ALARAs because physicians are wearing their badge through multiple months because they're not getting flipped out properly. And again, that's but again, it's like we're all big boys and girls. It's like the dosimetry badge is a part of your thing. You take care of your badge. You do it. But to them, it's just like it stays on the lead. It's on the lead. Wherever my lead goes, the badge goes. And if my lead's gone, then my badge is gone, and I don't know, so that's a problem. But I mean, it's been, so here's an example. So one of the recent TJC elements of where the facility had to establish radiation, this is for fluoroscopy, had to establish radiation safety, dose limits that require further action, that the patient has to then like be instructed for like self-examination. Didn't say what the number was. I think it's not NCRP 151. Where does that come from? Is it 151? But anyway, so we called it SRDL. And that NCR, what one is that, Mary Ellen? Is it 151? The significant radiation dose level?
No, I'm not sure, but.
You know the TJC
right.
element, right?
Yeah.
And then the other element was then that if a level was reached, then that kind of had to be talked about in some sort of like meeting to sort of say, oh, okay, talk about the radiation aspects of the case. I forget the exact wording of the 2 elements.
Yeah, it's that if the dose is to a single field, if
Yeah.
the dose is to a single field, it's high enough to cause some significant damage to the patient.
Right. And so there's a sentinel event that
That's a sentinel event.
right, which is 15 gray. But they said, okay, the institution has to pick a number. The number's arbitrary. That action has to go to where. I mean, they changed it. Now it went away. But I'm setting it up. Yeah.
Right.
But like, so we did all that. We created this entire thing to where we picked the numbers 5 gray, right? So it's just 5 gray. We couldn't, if it hits 5 gray, they have to do something. If they do this thing in Epic, and then it prints out on their after visit summaries like patient self-examination instructions and a number to call your physician. It's a really good thing, and I can audit it in real time. Like, so our dose monitoring software, if something hits, I get a notification. I can immediately contact people, get the skinny on it, right? Well, TJC took that away. And January 2026, that goes away. But I was like talking to leadership. I'm like, well, we should keep this still, even though it's not a regulatory requirement. It's now not a TJC requirement. We should keep it and get all the docs agree. So, and that was neuro, that was cardiology, that was vascular, that was IR. So all the major physician leaders came together and agreed, like, we should keep this policy, because so that's a good sign. So they're like, this is good, we like that you guys are monitoring this, let's keep it. So that's a positive. I was, first part a negative on the safety culture, but that's a positive about how physicians were, as far as safety culture. Other employees, it can be different. We're getting a lot of radiophobia from our nurses, which has been a challenge. Our radiology nurses, I've been getting radiophobia from a not a senior level, but a high level manager in radiology who used to be a nuke med tech. We're like had to do a full investigation because he's worried about PET patients walking past his office. And I'm just like, so we're getting more radiophobia than I'd like to see, and so but you mitigate that with education, and again, like you not being reactionary, because it's easy to do as professionals. We're like, oh my god, but we have to know, how can we help you? Okay, we'll figure this out, So yeah, I mean, but we're getting that our nuke med techs. I mean, that's that's a constant thing, So the culture used to be, if there's a spill, that's your problem. We've changed that pretty well. That years ago it was like that. It hasn't been like that for quite some time. Now everybody's sort of okay. Let's we're all gonna help. But there was a time where culture was sort of like the nuke med techs were kind of less inclined to sort of take ownership of stuff. That's all changed. So I feel like that culture is positive. But again, turnover, just always turnover, and so you're constantly having to retrain. And and that's always a challenge is staff coming from different places that are used to different things, trying to get them and again with 3 people and over 2,000 badges, it's really tough to be but I think we do a pretty good job.
Well, I mean, I saw that your return rate is like 85%, so you have to be doing a lot of investigations for lost CODs.
Well, so that takes into account on-time return. Very rarely do we have lost badges. If a badge is a day late, it's going to show up as not returned. So really, the lost badge count's really, really small. So that if they could just forget to put their thing in the thing a day late, and it's going to show up as not returned. So that metric skews worse than it actually is. It just means they were late. So that's an on-time return rate. It doesn't mean lost badge. Yeah. So. Yeah.
So what are some challenges you face when inaugurating like a new diagnostic or therapeutic treatment in your facilities? Like, do you have to learn about these products yourself and then kind of train the new, how do you go about doing that?
Go to the package inserts. I mean, it's just like, okay, so what is it? You have the breakdown, really. So at first it's like, okay, license, like, can we even do it? Okay, what kind of amendment would we need? Can the department handle it, just from an operational standpoint? And then it comes under the hood of like, okay, actually, like, what does this thing entail? And a lot of it is, looking at the literature. Anything that's been written about it, package inserts, start doing the calcs. Okay, where is it going to be? Assessing locations, training's obvious, but really it goes like license. Can the department handle it? With our license, we're spoiled because we can do so much. Like our license it covers just about everything, so we don't have to do too many amendments. But yeah, like you have to. You're just basically working a checklist, and then so for Lutathera, like when we did Lutathera in 2018, there was so many issues about bathroom, okay, the further that bathroom is away from your infusion suite, the more chances you're going to get of a contamination event. Yes. So we fought. This is before my time. This was Kayla and my predecessor. They actually got, so in the infusion room, they got an ensuite bathroom. And it was just like, holy cow, because that was pretty rare. Got an ensuite bathroom, but then it's like, okay, well, we need to administer amino acids. And people are like, what? No, we don't need to administer. Like, no, you're going to fry the kidneys, get amino acids. It's standard. At that time when we were commissioning, the people were like, why amino acids? Why amino acids? Had to fight for that. Because going through the literature, going through the actual science, and again, we have to put on those research caps. No one's going to do it for you. So as a radiation safety team, you have to go and put that hat on and dig into the literature and find the answers to these questions yourself, because no one's going to do it for you. Yeah.
We're encountering some phobia in our biospecimen lab
Oh, yeah, just for
like
what?
hot blood. You know,
For-
so we have volunteered to run, you know, the well counting. Do you have that in your?
Luckily with specimen counting, we're not, those folks, they're not, we haven't been getting called for that. I mean, they have, you know, well, I mean, they occasionally get something that looks like a prostate seed and they'll call us, but it never is, or if it's been decayed out. But as far as like,
Not
but as,
taking samples for, you know, for the research trials.
no, well, yeah, right now we don't have, well, any, like, I think the blood, everything, all our blood is super low, like, is bactinium, that even, that blood is not even labeled because it's so low.
Yeah.
But we did all those calcs to demonstrate it. Anything DOT calc, so we have to front end, okay, how do we need to prove through measurement or, you know, calculation that either what is so low, so we just do the math and
The
prove.
sponsors
You know.
are asking for the counts.
Yes, we haven't run into that, but I mean, yeah, like, having to well count the blood. Well, we're in this big thing, cause they were trying to get us to like collect, like urine collection.
Yep,
We just,
that's
and we just simply said like, look, we can't support it. And that wasn't Rad Safety making a call like, we don't wanna deal with this. This was operationally, so if we get a whiff from our nuke med team and our nuke med chief, if there's a whiff of, I don't like this, we stand up for him. And we're like, if there's even a whiff of, like, we can't do it, we step in and say, no, we're not gonna do it, and pull that card. But we wanna support research, but if operationally, if it can't be supported, you're not doing anybody any favors. Because the PIs, they'll do it, they just want the thing. But if they don't know, I mean, what, and we literally aren't set up for.
Urine?
Well, so yeah, that was like, so for the study, when we're Converge, they didn't want to do that, but even then we still had we couldn't collect. There was just no way. We couldn't store, we couldn't collect, we couldn't do any of that. But yeah, and then taking it home, that was a non-starter for us. We're not even, no, they need to figure out a better way. We're not just gonna do it.
Yeah, admit the patients, keep them,
Yeah.
make his deposits there.
But no, so the culture-wise, I want to say it's constantly evolving. Turnaround always slows things down. As soon as you think you've got a handle on it, people leave, and you're the last to know. And then who knows how many months of damage has been done with new people not understanding. And so you're just constantly, you know, if everybody stayed where they were at for decades, we probably would be good by now. But
It's a
not the
whole
way.
different set of problems.
Yeah, so that's not the way life works, you know. So when it's turnover, I'd say is the biggest issue with that. Yeah. Corey.
So you had mentioned physician culture.
Yes.
And I think that is a very powerful force. So people haven't experienced a medical system. It's really surprising how much that affects hospital, how you interact with physicians. So the culture is different depending, I think, on how much that medical system owns, so to say, their employee. But so you going from UCSD to Alvarado, did you see a difference in physician culture?
Well, so a lot of physicians kind of travel around, and it's kind of the same docs. A lot of the docs that were in like the rad areas, a lot of them left, but then our docs kind of stepped in. So they already kind of had that culture going in. We haven't had a lot of like physician issues at Alvarado or at East Campus, just because there's always kind of like it's funny, like even the few DBAs that we have like around town, a lot of those docs are ours anyway, you know, because the docs just travel.
Yeah, 3 of the AUs on their license were our AUs.
Okay.
For nuke med.
Yeah.
So you have good ownership, so to say, of those physicians, but if they work at other hospitals, they don't have that kind of ownership.
Who knows? Yeah, exactly.
Right, because in hiring your predecessor, we had a lot of consultant medical health physicists who applied,
Mhm.
and a lot of internal people as well. And one of the questions that we designed was a scenario where you just had to tell the physician no. Once you wrote the
Mhm.
scenario, the only answer was,
I remember that question.
you cannot do this, that is illegal, you have to stop.
Right.
And none of the consultants would say that. It was very surprising. Because what happens is,
Mm.
the physician, if they don't like the consultant, can just go to their administrative officer and say, give me another consultant, and they're
Sure.
out.
Right.
And so this is a very clear, like, you have to stop now, and nobody would say that, well, I would want to give them a copy of this, and I would say, here, you know, let's think about. And so I think in hiring medical health physicists, bringing people in, like you said, early in their career, I think is a really good pipeline for that. 'Cause it is kind of hard to get people from the outside in.
Yeah.
Building up through the.
For sure, yeah, and like, and that would be ideal. So, okay, so we're experiencing a bunch of growth. Hopefully the money comes in eventually. I can bring in someone at that early career level. But if one of my high level people leave, you can't like, you know, you can't just like train an early career person to do a job that should have a 10-year professional in it, you know?
That's very true.
So yeah, but ideally, yes, as a growing program comes in, bring in that new blood, train them how you train them, mold them, mentor them, and then it's all good. But yeah, no, we're in a niche field, and it's really, you know, that talent, it's like tough to retain. And
Yeah, we lucked out with our RSO.
Yeah.
I want to mention, oh, I'm sorry, go ahead.
Our RSO was an inspector with the state, and she's also a lawyer.
Oh yeah, Barbara, right? Yeah.
So when she puts her foot down,
Yeah.
they listen.
People listen. That's great. That's great. Yeah.
So one thing we're doing at Kaiser Permanente that may help a bit with the pipeline is we have a medical physics residency program. It's 2 years of diagnostic medical physics, 1 year of nuclear medicine physics. But in that 3-year residency program, they work very closely with me as well. So I make sure they get enough radiation safety training hours in the right categories. So by the time they finish their residency, they qualify for RSO or ARSO.
That's great. Is it camp ep? Is it like?
Yes.
Oh, that must be nice.
Yeah, our rad-onc department has a residency, but we're not involved in that in any way. They have their thing, but that's through radiation medicine and not through.
And as far as badges go, the doctors are our worst offenders.
Yeah, I think that's ubiquitous everywhere.
I mean, yeah.
I think
It's
it's
like the
ubiquitous
higher
everywhere.
degrees they, forgive me for anybody else, but it's like the higher degrees they get, the stupider they get.
Right.
You need somebody
Yeah,
to
I
go
mean-
and put the badges on their apron and take them off of their apron and change them for them. That's what you have to do.
Yeah, she's right.
Do you guys do that?
Yes, well, not my team, but we have an on-site badge manager.
Yeah,
for
we
each
have to
department.
delegate it
And
to
the on-site badge
to the
managers.
LV, the nurses,
Well, you
LVNs
know,
and stuff.
You can only do so much. I mean, we have different groups and we have coordinators for those groups.
Exactly, same thing.
But some of our coordinators, it's like, they don't, like, we have one doctor group, they haven't turned in their badges in over a year.
Yeah, it's pretty bad.
And we try to get, and we call and send emails to the coordinator, not a peep.
Yeah, it's bad.
Hey Chris, not to keep sort of, but, so Alvarado's a specific license, your broad-scope license, but Alvarado is only, what, 100, 200, your license for?
Yeah, we're not doing any 300 right now.
Okay, so that makes.
No
That
400.
makes it a little bit easier, but had you acquired Tri-City, that has probably 400, 600,000.
Well, see, I think so. Right? I don't think he's gonna have a problem just making Alvarado broadscope with parity. I think like if the state's gonna decide that okay, I think everybody understands that the state loses revenue for having having places gobbled up under one umbrella, but I think they will be understanding that okay, if you're gonna have an RSO of a broad scope license under this, that just make the license broad scope. They charge more money for it, you know. But it'll help because I think what they're gonna find is we're already complaining. We've had to change one room, but I think it's on Jeff's radar to like okay, just if you know we get it, have the separate license, but we gotta have parity with.
Yeah, I
you know,
agree with you,
with
broad
ours.
scope, but you're in a weird spot right now where
It's a weird
you're
spot.
administering a specific license from a broad scope mindset, which is really kind of hard to focus back on.
Yeah, we had to tell the state we want to inject MMA in cath lab, and it wasn't on the original thing. We had to like call the state and tell them add it. Whereas before we just put it on RUA
Yeah, just go,
and
okay,
done.
yeah.
We have our RUA and that's done. But yeah, so yeah, that's a thing we're still working on. Yeah. Yes.
So how are you keeping your students safe? It was interesting, I was on a plane with, I think, a resident from what college was that?
Brown.
Brown.
That
And
medical students?
She was saying that, she was an orthopedic surgeon, and she was saying that they are given like one, lead apron, and that if it like gets broken or if something else happens, that they have to buy a replacement. And that they also don't have access to more than one lead apron, so they'd have to carry their lead apron from like one site to another. And I was just wondering, is that just generally how things are done? Cause to me, it didn't seem
No,
like
that's
super
bad. I
safe.
don't care. It's incumbent on the department. If you have, and so we require, if you're in a fluoro suite, you're required to wear lead with the 2.5 millimeter equivalent lead, right? I mean, and that lead has to be available. We don't care how they get it, it's gotta be available. Usually, so, and we make that incumbent on the department, really, because I mean, lead's expensive. People have to buy it, but it's one of those things where you just, there can't be a situation where you have a care team involved in a fluoro case and there's not enough lead.
Yeah.
If that's the case,
happening at the
I mean,
university.
that's a non-starter, and that's something that gets pushed up the chain pretty quick. The only time I've heard of that was more of like, bad info was given, it wasn't like, but I've never really heard a real story of someone like not getting lead, like being forced to work in a fluoro suit without lead. That hasn't happened, under my watch at least.
And also, Mary Ellen, when are your fellows going to come lecture to us? Cause
Oh,
they
they
were,
need to.
they were supposed to present sometime, so
Yes.
keep that on your radar.
Okay, yeah,
Um,
definitely. There's 6 residents right now. They all have to do a research project, so.
Yeah, so
Did
Mary
you have a
Ellen had
question?
offered to have the residents present to us, which I think would be really great for them and us, so.
Cool.
We had one resident who did a great project on dosimetry badge reduction.
Oh.
Because we're badging, I know, 2,000, right, but we badge 8,500
Yeah.
people.
Right.
And so we were looking to see where can we reduce. So he looked at the previous 6 years of data for 8,000 people. And this was good because he had to do large data analysis, right? And so he was able to use some really great programming skills. And he actually stratified dose history not only by department, but also by physician versus non-physician. So we were able to reduce some of our badging, for example, for surgery. We badge the physicians and the PAs, but not everyone else in surgery, based on his results.
Yeah.
So he is actually working on a paper for that I'm encouraging him to present at the next HPS annual meeting, and also submit for publication in operational radiation safety.
Cool.
And that being said, tell them the date.
Oh, yeah, I thought I'd mention that I got an email, I think it was just today, from the National Health Physics Society announcing their topical meeting. It's the middle of February, and it is a medical health physics seminar for 2 days. It's all virtual, so you don't have to travel, and it's on medical health physics. It mentioned the alpha stuff that you were talking about.
Oh, yeah.
So if you're not already a member, I'm sure that there's a fee if you're not a member of the society for attending, but it's a lot cheaper if you are a member. And Bridget sent out a note about the discounts available to join the
Yeah,
society.
if you haven't paid your dues in a while, you get a discount if you rejoin, which I thought was kind of funny. Or if you're a brand new member, I think they're continuing.
It's only $30 still, right? Or what do you guys?
No,
Oh, for
not
national?
ours.
Oh, for national. Oh,
National
yeah, I'm
is
dialed with
a couple
national.
hundred,
I think
yeah.
I'm currently.
We may be raising our rates, guys, because they're really low and food is expensive, but it's gonna be, we're upping it to a whole $30, so hopefully. And if definitely the students still have to pay 20 or whatever,
Yeah.
so, but.
If you need to take out a second mortgage, do it now.
Yeah,
Our first treatment is next week. We've done.
Thanks, guys.
That was honestly,